Okay, well, thank you so much to Dr. Yolanda Becker for presenting. She is a surgeon at the University of Chicago who specializes in kidney transplantation. And she was also involved in a triple organ transplantation on 2 people, which continues blowing my mind. And I'm looking forward to the presentation.
Great. Thank you so much. It's a great pleasure to be able to do this kind of lecture across the world. It's one of the more cool things that I've had the opportunity to do. And so I really appreciate meeting colleagues from around the world. And I look forward to talking to you today a little bit about kidney and pancreas transplant, mainly kidney transplant, and how we get patients to the list and some of the basics. I know that we have a urology audience today. And so I'll review some of the basics of kidney transplant. As you know, in the United States, several of the transplant surgeons in some of the largest centers in our country are actually urologists. And it's a very good basic training pathway to come through to transplant from urology. I'll present what criteria we use in the United States for listing patients, how the organs are allocated in our country. I certainly would love to learn how they're allocated in yours, and present some of the criteria and some of the challenges we face in actually, unfortunately, needing to delist patients prior to them being transplanted. As you know, all the patients want to get off the machine. But I always tell them that a kidney transplant really is a form of kidney replacement therapy. They can do hemodialysis or peritoneal dialysis, but obviously we certainly believe that kidney transplant is the best way to go, leading them to a better lifestyle and for many patients a longer life. Our patients try to avoid starting dialysis altogether. It certainly affords them better health than remaining on dialysis, and it does add years to their life. I'm going to show you an app that I'm developing with one of my collaborators, Will Parker, and another Robert Gibbons, and Dr. Gibbons is a well-known economist at the University of Chicago. So they're doing the math part, and I'm giving them the clinical background where we can show patients in a visual method on an app from our phone that a successful kidney transplant will add years to their life. And I'll actually show you that app. So when patients get to the wait list, in the United States, it's governed by the United Network for Organ Sharing. I was fortunate in 2017 to be the president of that organization, and that is really the governing body for organ transplantation. That UNOS is actually the contractor that runs the organ procurement and transplant network. It maintains the list of everyone waiting for transplant in the United States across the organs: heart, lung, liver, kidney, pancreas, and multi-organ transplant. In our area, and I overheard you all talking about how right now that the programs are on hold for political unrest. However, one would hope that very soon, for many, many reasons, that COVID is under control, that the political unrest at least allows us as physicians to take care of patients and to move forward. However, in Chicago, our waiting time for a deceased donor kidney transplant is between 5 to 8 years, which is quite a long time for a patient to wait. And the waiting time right now is at the start time of how many points they get on the waiting list is either the start of their chronic dialysis, or if the patient has access to healthcare, then their qualifying date starts when their GFR is 20% or less. Now, certainly in the US, we've seen where this leads to significant racial and ethnic disparities, because most of the patients that have private healthcare insurance or can pay can get referred to a transplant center before they're on dialysis, leaving those who are a more underserved population only being brought to the list when they've been on dialysis, sometimes for quite some time. That actually is better than it used to be. It used to be that the waiting time only was based upon the listing date, and that clearly led to significant inequities in patients who were frightened to come forward for transplant or didn't have the socioeconomic means to have a copay to pay for their medications, the copay on their medications. So now it backdates. So if a patient comes and they've been on dialysis for 5 years, then they've got 5 points of waiting time, and they will pop to the top of the list, which I do think is it is a scarce resource. We have organ procurement organizations, and our transplant, the logistics of how transplants are procured and also then allocated are known as organ procurement organizations. And our OPO is known as the Gift of Hope in Chicago. All the transplants and the logistics are coordinated by the OPOs, including getting teams to and from the various centers. But it used to be that it was just the Gift of Hope, or a very localized area, actually in kind of the city of Chicago. What that led to in the United States was a geographic disparity that wasn't supposed to exist. So for instance, if you went 90 miles north into the state of Wisconsin, the waiting time for kidney transplant was only 1 to 3 years, where in Chicago and Illinois, it was 5 to 8 years. That was never supposed to be. So literally 1 month ago, the allocation changed, and organ allocation is now across a 250 nautical mile zone. So if you hear my phone going off, it's because our patients are now popping to the top of the list and have equivalent waiting times to the people in states like Wisconsin, Indiana, and Iowa. Those are our geographically close states, and those patients, they don't have the burden of disease that we have in Illinois. So this is helping to decrease yet another disparity that existed in the United States. So the organ that the patient receives may indeed come from another state or region of the United States, but since they are receiving their transplant in Chicago, all of their post-transplant care will also occur in Chicago. However, our patients do have the right to list at multiple institutions if they wish. They can transfer their waiting time from center to center. However, the post-transplant care will take place at the center in which they were listed. This is very important because, as I said before, people would travel 90 miles north to get a transplant sooner, but then they would come back to us and want us to take care of them long term. But there are many reasons why that was not something that in the United States is easy for us to do, with the way payments occur, with the way centers get followed for outcomes. We didn't feel comfortable doing that. So this new rule prevents patients from having to shop around, if you will, or be inconvenienced by driving so far to receive their transplant and follow-up. So we tell patients now that there's no advantage to listing at the multiple centers within that 250 nautical mile radius, because all centers receive the kidneys from the same donor pool. Our outcomes are followed very carefully, and we have expected 1-year outcomes. Surprisingly, they're actually quite high for University of Chicago for living donation. Our expected 1-year survival is 99%, which is quite obviously exceedingly high. As I tell my children, that's an A+ in anybody's book. Our outcomes are followed by the Scientific Registry of Transplant Recipients, also another contractor to the US government that compiles all the performance statistics for every transplant center in the country, as well as every organ procurement organization. And the data is collected over a rolling 18-month period of time and released every 6 months. By way of disclosure, the data must be given to all patients on our list. So all the patients get the updated SRTR data. Most patients aren't going to look at it, but we are required to provide that information to them. Our patients have quite a bit to do when they come for the transplant evaluation, and they are often surprised at the number of people that they need to meet with. They meet with the nephrologist and the surgeons, sometimes either or sometimes both. They must, by the regulations of the Organ Procurement and Transplant Network, or OPTN, they must meet with and have an evaluation by a social worker, a pharmacist, and a dietitian, and a nurse coordinator coordinates all of this and must also leave a note about whether they judge the patient able to be able to deal with a complex medical regimen post-transplant, because clearly we would like the kidney to last for as long as possible. We require many, many blood tests, infectious disease screening for things as what you might expect, like hepatitis B and C and HIV, but also things like Trypanosoma cruzi. So it is, and West Nile virus. So as we discover new illnesses, all of a sudden in the transplant world, we add more tests to be done. We do get the routine chest x-ray, and of course cardiac testing is exceedingly important for anybody undergoing kidney transplant, because there is a very large burden of cardiac disease amongst the end-stage renal disease patient population. All of our patients who are over the age of 40 and diabetic receive a stress test, and many, if I would say 85% of our patients actually meet the criteria for consulting with a cardiologist, in addition to the other physicians that they see. So that we sew the kidney to the iliac vessels. So we get a non-contrast CT scan for many patients so that we can see if they have concentric calcifications. And certainly, as I'm sure you experience, once you order one test on a patient, there are many other tests that need to be done beyond that test to finish out the workup. So sometimes the process of listing can take several months. One of the things that we found most often, and because I was talking to a urology audience, I thought it would be important for me to show you one of the things that we collaborate very closely with our urology colleagues. This is an algorithm that Dr. Scott Egener and I put together, because we had so many patients that had kidney masses in their native kidneys. And then we would say, well, do they, and these are masses that you all as urologists would really, you'd follow them, especially if they were cystic and they were small, as we titled this, our SRM protocol, small renal mass. And, even if they're transplanted, some of these can be followed by active surveillance and do not require transplant. The reason why we were so passionate about this is we did have some patients who underwent native nephrectomy and had very bad outcomes, wound infections, but and or ended up being on dialysis rather than not on dialysis if we had been able to wait out the native nephrectomy. But we in transplant were saying, well, that's a cancer and we're going to immunosuppress them. So we actually have this protocol, and we found this to be very, very successful. So as you can see, we don't always get to native nephrectomy. Native nephrectomy is actually quite far down in the protocol in the algorithm. So as I noted before, I think cardiology is almost not a potential consult, but something that is almost surely going to happen. However, several of our patients need to see psychiatry because frailty is such an important component in our patients, and potentially trying to do prehabilitation prior to surgery to increase their strength and mobility prior to surgery is important. So we have our geriatrics department see everybody over the age of 65, which is about 30% of our list. So it's quite a number of patients. Of course, many patients have diabetes when they walk in, or they will develop diabetes post-transplant. So endocrine is also another consult, or hepatology for those patients who have a liver disease. And our patients also, again, because they're diabetic and because we also know the relationship of periodontal disease to future infections and potential for increasing an inflammatory milieu, that thereby increasing the chance for rejection, our patients do need to have dental and eye clearance. Dental clearance, as you know, they don't have to have everything done. Certainly in the United States, when the dentists see some of these patients who have never received dental care in their lives, we end up having, they end up recommending literally tens of thousands of dollars of dental care. And that's not what we need for clearance for transplant. We merely need any abscesses or severely decayed teeth to be dealt with. So we all know that patients with a higher BMI have a risk of complications both during and after transplant. as I mentioned earlier, when they get wound infections, this recruits inflammatory cells, which subsequently leads to an increased risk of rejection. And there's a statistically significant increase in risk when the body mass index is over 35. We don't stop them from getting a transplant, but again, it's that idea of trying to get them as healthy as possible prior to transplant, because we know that higher BMIs also have an increase of delayed graft function, graft failure, certainly difficulty with cardiac disease, and if they didn't already have diabetes, the chance of getting insulin-dependent diabetes after transplant is also something that is very difficult for them to understand. However, you will see that our criteria are actually quite loose. To start the evaluation, their BMI merely has to be 40. For listing at transplant, the BMI should be 38. So we will evaluate them and hope that they lose a little bit of weight as we continue the talking to them and educating them about the importance of why BMI is so important for them. And as part of their evaluation, they are hooked into a dietitian. So we are not leaving them alone to, oh, you need to eat right. We all know that, that food and nutritious food very often is very difficult to obtain, and certainly in the United States, far more expensive than things that are less healthy. If we have somebody who's being evaluated for a living donor, because of the relationship with high BMI to renal subsequent renal insufficiency or renal failure, if the donor is under 40 years old, we ask that their BMI be less than 32 at the time of donating their kidney. If the donor is over 40 years old, then we know that the window of time is a little shorter in terms of their lifespan. Therefore, we let the BMI, and as we all know, as we get a little older, BMI is a little harder to maintain. We allow the BMI to be a little bit higher. For kidney and pancreas transplant, whether they're type 1 or type 2 diabetics, we like them to have a BMI of 30. And again, the registered dietitian meets with all patients and follows those with a high BMI and nutritional concerns. She also follows up with them by telephone. And actually, it's been very nice that we have increased our ability to do telemedicine in the United States. The psychosocial determinants of disease, or the social determinants of disease, are quite significant for transplant because our patients need to have a plan for post-transplant. And as you look at different types of communities, can somebody bring them back and forth to the transplant center? Or do we as clinicians need to go out into the community? I actually have 3 different community clinics where patients can't, it's harder for them to come in. The bus routes are difficult. So we actually do go out and do some follow-up, but we still need to have the patient to have caregiver support. Somebody still needs to get them out of the house and bring them to the clinic. And these clinic visits can be quite frequent. When they have delayed graft function, we may see them as much as 3 times a week. We need to make sure that they have appropriate and safe housing, clean water, in the United States, sufficient insurance coverage. Can they work with us as the transplant team? We certainly, and I'm sure you experience the same, have patients that always like to negotiate things, if you will. And negotiation is fine, except that at the end of the day, they need to be able to work with us and not be angry when we tell them things that they really need to do to keep their organ viable. We also ask them to have demonstrated adherence to their current medical regimen, meaning that they, certainly we all know that life has been very difficult over the last year. So we would like them to be compliant or adherent and show up for all their dialysis sessions. However, we recognize sometimes they can't because of COVID and things like that. We ask that they make at least the effort to call. If they can't come and it's not urgent for them and they can go a couple extra days, they still can demonstrate adherence by calling and canceling rather than simply not showing up for their sessions. And again, that's that ability to make that phone call or get a message to the team shows us that they can do a little bit of problem solving on their own and also manage this very complex medical regimen after transplantation. All patients must have their cancer screening prior to being listed, again, to make sure that there isn't any active cancer. In females, they need to have pap smears and mammograms if over the age of 40. Now, of course, one of the reasons why we are such good collaborators with our urologists. We get a PSA over the age of 50, and as you know, obviously, oftentimes we get a slightly elevated PSA. So then we have to go to the urologist, and so it is a fun collaboration that we have. Actually, I found out from Dr. Egner that I am his #1 referring physician, so that made me smile. And we do ask certainly for colonoscopy if over the age of 50. However, those guidelines, because of the incidence of colon cancer, are now dropping to age 45. The insurance companies haven't caught up with that yet, and sometimes they won't cover it. However, we are recommending to our patients now, especially if there's a family history of cancer, that they start getting their colon cancer screenings much earlier. And since I told you earlier that the patients might wait between 5 to 8 years, current testing is required when the patient is getting close to transplant. And then once they get all of that done, then the complete evaluation is reviewed by the multidisciplinary team. So the complete evaluation includes all the x-rays that have been done, all the notes from all the consultants that have seen the patient. And then a group of us sits around now in little boxes on Zoom with physicians, nurses, the social worker, dietitian, pharmacist, and also our financial counselors to discuss the patient and to say, does anybody see that there's a problem? Does everything look pretty good? Sometimes somebody that you think is going to have a lot of problems is surprisingly, really put together, and they can get everything done. And sometimes, that 20-year-old who really doesn't want to admit that they have renal disease is really not ready for a transplant. But we try always to get to yes, because we know the answer of yes is most important for the patient and their lives. So sometimes, but we may make one of several decisions. One is to be honest, the easiest in terms of having to talk to a patient and feeling good about what we do is that they're approved for listing. That's a wonderful feeling for both us and the patient. Sometimes further evaluation is needed. And you can imagine after going through everything they've gone through already, that can be a little bit annoying for the patient, but indeed it's very important. I think the hardest thing for us to communicate and for the patient to hear is that they are not a candidate for listing. That certainly is difficult for them, for their hope, and very difficult for them in terms of moving forward. We do notify the patient, the patient by phone and in writing of the what their status on the list is. Transplant medications are very costly, especially in the first months following transplant. In the United States, Medicare covers the first 80% of anti-rejection medications, but that still leaves out-of-pocket costs for our patients as much as $300 a year. And the anti-infective medicines, particularly the antivirals, are even more than that. And so that is quite a bit of money. And that's why our patients are required to have an adequate secondary insurance or notify us as soon as possible about any insurance changes. We did recently have a bill go through Congress where transplant medications will be more of the transplant medications will be covered under the Medicare benefit so that the out-of-pocket costs will not be so much. I think I noted in the chat that somebody said that in India, the nephrologists are much more involved with the preparation of the patient than the transplant side of things. And that would be wonderful. In the United States, it falls to us in transplant. I think there are many initiatives where we hope that the nephrologist will have the funding and the ability and the time to help partner with us even more closely so they can be ready for transplant. And of course, as you know, that just getting on the list is one thing, and then we have to find a kidney match for them. We always tell patients that the living donor is preferable to eliminate the wait for transplant. They don't have to be blood type compatible, because in the United States, we have a swapping program where if your donor is not compatible to you, but agrees to donate to a stranger, then a stranger may have a donor that is compatible with the recipient. And then on the same day, everybody goes to the operating room and we literally fly the donor kidneys across the country and we swap the kidneys. There have been some interesting papers about doing that by drone, or contracting with Amazon, who seems to actually never lose it, they get our packages to us very quickly. Sometimes we feel like we have to wait a long time for a kidney. So, but still living donor is preferable. And even when we're flying kidneys around, that short time frame of flying still results in a better outcome. So we don't, the donor doesn't have to be blood type compatible. And then we talk about the various issues surrounding deceased donation. For living kidney donation, really, it's the best option. It's got the best outcomes. It's expected to work the longest. There's no long waiting time. It can be scheduled ahead of time. We can make sure that we have all the medications. We can pre-treat patients if necessary. We ask that the donor be over 18 years old and healthy, within the weight limits that I mentioned before. We say that the blood type must be compatible if they're donating directly, but we tell them that's not a necessary thing because we can swap. The donor must not be forced to pay or paid to donate. So if there's any chance that a donor is we uncover anything that we think is coercion, we will not allow the donation to go forward. In the United States, the donor also has their own evaluation to make sure the kidney removal is safe and appropriate, and they are completely separate. The donor has his or her own evaluating team, as does the recipient. And until the donor has been accepted as a transplant, as a donor for transplant, we keep those teams very separate. So there's no chance for any unfair bias, particularly to the donor who doesn't have to have this surgery done. The potential donor is not financially responsible for any part of the cost of the evaluation. The recipient's insurance pays for that. The donor undergoes a thorough medical and psychosocial evaluation, very much like the recipient. They have to be healthy enough for surgery and certainly have enough kidney function to give up 50% of the kidney, although ultimately we tell them you're not going to divide your kidney in half. You actually will recover a lot of kidney function from your remaining kidney. We also are very careful to make sure that they can cope with loss or unexpected outcomes. Through no fault of the donor, the recipient could get very sick. Through no fault of the recipient, they may get thrombosis of the organ and never be able to enjoy a time off dialysis. So we want to make sure that especially for the donor, that we deal with that we let them know what the potentials are for complications, so that if something happens, and we tell them it's exceedingly rare, but if it does, that they understand that they have still done a wonderful thing and they're still coming forward. We also tell them we will not share information about the potential donors with recipients. So this "you" is actually directed at our recipients, because the recipients are always trying to call in and say, well, there were 20 people who said they called, and we simply say not that way. Sometimes it makes people angry with us. They try to get information, but really the donor's information is private health information. And it really isn't, we don't want to get into family dynamics that somebody said they called, but they didn't really, or they called and then they never, when we tried to call them back, they gave us a disconnected number. That happens all the time. And when the recipients start blaming us and get angry, we have no choice but to simply smile and shake our heads and just understand that we're going to get yelled at. Some days that's just the way it works. We work in a paired kidney donation exchange through the National Kidney Registry, which has a database to find other pairs that are compatible between the patient and the donor. We talk about the risks and the benefits. We talk about the geographic distance that something has to travel. We have never lost a kidney. No kidney has ever suffered because it traveled long distances, but we make sure that patients know. And certainly I live in Chicago, which in the wintertime, sometimes we have to take into account the weather and whether or not the planes are going to be able to fly. And if there's a major blizzard or something going on, then we might actually postpone the swap until the weather passes. The other advantages of participating in the kidney swap system is that they have a voucher system through the National Kidney Registry, where they, any person who donates a kidney gets 4 points in the United States system if they ever need a kidney transplant themselves, which is like 4 years of waiting. It puts them near to the top of the list. However, the National Kidney Registry, which is actually a privately run organization, has enough non-directed donors, meaning people that just come forward and say, I want to give a kidney, and because kidney failure in previous kidney donors is a rare event, the National Kidney Registry offers a voucher system that if you give your kidney to somebody, if you ever develop kidney failure in your future, then you have a voucher in which to receive a kidney. Some patients have said, well, I want to give my voucher to my son because I know that my son carries from his mother polycystic kidney disease. He's only 3 years old right now, so we don't really know, but I want to make sure that I'm giving my kidney in advance so that my son gets the voucher. And that is something that can be done through the National Kidney Registry. So that's a very attractive. So even if somebody's blood type compatible, they still may want to participate in the registry because we can't do this through our government. The donor through the NKR is also offered insurance, which we can't do through our university setting, but they can do because they are one step removed from the university setting. So they can actually offer some insurance coverage for the donor as well as lost wages compensation. This is not considered paying like, somebody can't come through and tell you they make $500,000 a year and you will pay them the lost wages for that. But it does allow for reasonable wage compensation, which is allowed in the United States. But you can't pay for a kidney. You can't go out on the black market and buy it, but you can pay for things like lost wages. And if the donor has to travel to donate, you are allowed up to a certain amount to be able to cover that expense. But the National Kidney Registry actually has a whole program, and it makes it a lot easier for the potential donor to partake in that program. Then, of course, if you have no living donor, then there are the deceased donors, which I'm sure you all know about. They are either brain dead or donors present after circulatory death, where all of the ventilator and pressors and everything like that are removed. And we see if the patient does indeed go into circulatory arrest. And if so, a short period of time is given before when the heart stops, and then we declare death, and then organs are procured. The person who declares death in the United States is never a member of the transplant team, so that again, there's no chance or no appearance that the transplant team is somehow declaring somebody dead for the purpose of their organs. Donors, the kidney gets a score from 0 to 100. The higher the score, the less time the kidney is going to last, over 10 years. And donors with scores that are over 85 are those kidneys that come from people who are slightly older or may have diabetes or hypertension themselves. There are also now, we know that we can cure hepatitis C. So we are offering recipients, donors who have blood test evidence of hepatitis C infection or that have been exposed to hepatitis B when the recipient has been immunized. And we do also present our recipients with donors who have risk criteria for an infection with HIV or hepatitis B or C, but somehow our NAT testing is incorrect in terms of a negative test. However, we all know that NAT testing is exceedingly sensitive and rarely wrong. So I tell patients the chance of the test being wrong is far less than the chance that you will leave my office and unfortunately get into a car accident. So there are brain dead donors where the death is declared due to complete and irreversible loss of all of the brain function. or they remain on the ventilator with a heartbeat up until the time of the procurement. The ventilator is removed and we await the cessation of the heartbeat. If the heart does not stop within about an hour, then unfortunately the patient returns to the ICU and is usually is in a permanent vegetative state until such time as they die. So for circulatory death, they have minimal function, but they can't be declared deceased because they still have some brain stem function, or they have some minimal function. So we can't declare death until after the heartbeat stops. We expect that those kidneys are going to be slower to wake up after transplant and will very likely have some delayed graft function. And in the United States, it's about 20% of our deceased donor pool. The patients do need to sign an extra they have to sign a consent for that. However, but we tell them it is a way to get a kidney a little bit faster. And there are several things that can help predict how long it will work. There's the score, as I mentioned, that is the kidney donor profile index. And the lower the score, the more likely the kidney will function. And the donor kidneys with higher scores still work. Then we do some life expectancy matching, where those patients with the longest expected post-transplant survival based on age, whether or not they have diabetes, how long they've been on dialysis, or whether or not they've had a prior transplant, is matched with the KDPI score. So the best 20% of KDPI donors will be offered to recipients with the lowest 20% EPTS scores, so that the kidneys expected to function the longest are given preferentially to the patients who are expected to live the longest. And the over 85 will only be considered for those patients that gave written consent. However, if I can make this work, I'm going to show you this app that will show you that this is something that we've been working on, that will show you that if you have a patient who's age 55 and they've been on the waiting list for some time, the red line is their survival if they stay on the waiting list. The blue line is if they receive a kidney. As you can see, the blue line doesn't move very much as the KDPI goes up and down. But certainly if you have diabetes, you can see how all the lines switch down. And if you're diabetic, you can see down here at 5 years time, you have a 35% survival benefit, or a 35% greater chance of being alive at that point in time if you went ahead and took that kidney rather than waiting on the waiting list. So this is a nice tool that we use for our patients so that we can show them in real time what it means. Both the living and deceased donors go through a thorough evaluation, being screened for infections, but there's nothing that's risk-free. Therefore, our recipients are required to have HIV testing and hepatitis B and C testing, both before transplant and 4 to 6 weeks after transplant. And again, all the organs donors are evaluated. And if they meet any of the 10 different risk criteria, and I'll show you the risk criteria. I'm not going to read them out. And you're certainly welcome to the slide set so you can see in the United States what those are. The patient can then choose to accept or decline the organ. And declining the organ will not affect their placement on the waiting list. And accepting for an organ from a donor that has these risk criteria of the NAT testing being incorrect, it actually may shorten their waiting time significantly. These are the 10 different donor risk criteria. As you can see, some of them are pretty significant, and some of them are just simply an unknown medical or social history. So again, I usually counsel patients that these are very reasonable kidneys to think about taking. So for our patients, the incision is usually in the lower abdomen. You can see we actually usually go on the right versus the left because the iliac is a little, the iliac vein is a little more surface. But again, you can see the transplanted kidney. We do a leash technique that's supposedly anti-reflux, but I think my urology colleagues would certainly argue that the transplanted ureter almost always refluxes. It's about a 2 to 3 hour operation. We usually have people in the hospital less than a week, even if the kidney is a little slow to function. We let them go home and partner with their dialysis centers. We anticipate full recovery in about 12 weeks, but we don't let them lift. You know, this is general, general post-operative rules. The difference, though, is, as I mentioned earlier, that they may have frequent transplant visits, clinic visits 2 to 3 times per week until they're healed and their kidney has started to function properly. We tell our patients, know your status on the list. The most recent, we send them letters every year to tell them whether they're active or ready for transplant. If they're on what we call an internal hold, where they're temporarily not ready. Maybe they had a toe amputation that's going to heal, or they have a pneumonia that's going to heal. Certainly patients that have gotten COVID, which we sincerely hope they will recover. Unfortunately, sadly, many don't, but we put them on internal hold for if they contract COVID. However, some patients are on inactive status, meaning they're still on the list and they are still gaining those waiting time points, but they're not ready to be transplanted because they're too sick, because their evaluation's out of date, or they simply need further testing because something about their disease has progressed. When they're listed for transplant, they've been cleared by the team, but we tell them their situation can change. They need to tell us, and we need to periodically perform a full reevaluation to determine if they remain a good candidate for transplant. And in a very short period of time, that is the long and short of what we do in the transplant world in the United States and in Chicago. I wanted to leave a little bit of time for questions if you had any, and I've certainly been honored to share this time and this space and this Zoom meeting with you. Thank you.
In Uganda, we're trying to set up the transplant program. We haven't done any. We've had a bit of training, a few, and but our nephrologists have been participating in preparing patients, and then they go in there, they get transplanted, they come and they take care of them. A little bit more exposed to transplant than us surgeons. Now, my question I wanted to ask was about insistence on living donors. Do you insist on first relative first? Does patient have first?
Yeah, that's a great question.
Have confirmed that they have first degree relatives, or do anyone compatible they bring them on?
Yeah. So the person does not have to be a first degree relative as a living donor. We will evaluate anybody that somebody brings forward that we feel that we're sure that is not being forced to do this. We've had some interesting situations. I once had to evaluate somebody who was as best we could tell, a mail order bride. And so that was a tough situation to know whether or not she was really wanting to donate a kidney, or if there was some other issues going on. So, but we don't require it to be a first degree relative. It can even be a friend.
It looks like we have a question from Dr. Kigango.
Yes. Thank you, Dr. Kadi. Thank you, Dr. Yolanda, for your time and presentation. I think some questions I didn't understand about eye clearance. You send your patients for eye clearance. You help me explain some more about that.
Yes, because many of our patients are diabetic, we like to make sure that they don't have any retinopathy. But to be quite honest, the reason we have to require the eye clearance is because many of the insurance companies in the United States require the eye clearance. I mean, we understand that many of our diabetics may go blind at some point in time. Having good glucose control and good kidney function actually may stave that off a bit. So we try to remove that as a barrier, but unfortunately, it's mainly the insurance companies. There's nothing about the eye clearance, quite frankly, that would stop me from doing a kidney transplant. It's not like having at least the dental abscesses treated. This is a United States insurance company driven situation, in my opinion.
Okay, I have two more questions. I think about smoking and alcohol. Smoking cessation will be obvious. How is alcohol use in a transplant patients?
Yeah, that is a great question. And of course, right now, you know, what about vaping? What about marijuana? Because that is legal in many states in the United States, not uniformly, but it is legal. So, you know, if the patient is diabetic and is smoking, very often they have significant cardiac disease. So we like our diabetics to have smoking cessation. For use of alcohol and marijuana, that's a little trickier. For kidney failure, and actually now, even for liver transplant, and I mainly do kidney transplants. I mean, I can do a liver and I help them often, but for liver transplant, they are actually even starting to do liver transplants for acute alcoholic hepatitis. You know, the issue being though, if somebody uses a lot of alcohol, do they have the ability to follow the medications? Do they have the ability to get to and from clinic? So that becomes same thing, you know, with marijuana use. It is a very difficult circumstance. We don't require that they stop for kidney transplant, but we do put them into alcohol and drug rehab type programs, and we try to follow it as carefully as we possibly can.
Okay, thank you. And another about complication rates for the donor, the process of donation. How do you counsel them? What is the rate of
you know, the rate of complication, and we include things like, you know, urinary retention. I mean, you know, if you count everything, the rate of complications is very low, between 3 to 5%. The chance that you will die from the donor operation, because certainly that can happen, is less than 0.01%. We do tell them that there is a risk for a PE or something like that happening. We think it's exceedingly low. Some of our colleagues now are actually our urology colleagues, Dr. Arya Shalab and also Dr. Egner. At times we have asked them to help us you know, come into the latest thing in the United States, which is robotic surgery. And sometimes they help us do the donor operations through the robot, which actually has even fewer complications than the traditional open way, you know, where you had to go through a subcostal incision and retroperitoneum, and sometimes we took out a rib. The laparoscopic or the robotic, as you know, is very, is not very difficult for the patient. Actually, our donor patients, we treat with abdominal wall tap blocks, so regional blocks, as well as gabapentin for pain. So they go home on postoperative day 1 with a non-opioid pain medication protocol. So the risks are very small. The 3 to 5% is usually urinary tract infection or some nausea, GI upset and things like that. But even the GI upset has gone significantly lower since we stopped using opioids and narcotics for pain medication.
Let's see. My last question to so far, what contraindications to transplant, apart from maybe a patient not being fit for surgery? Any other?
Certainly if they have active malignancy, if they have significant cardiac disease that cannot be adequately managed. So significant coronary artery disease, ejection fraction less than 35%. So we get into this very difficult circumstance where patients' ejection fraction is, between 30 and 35%. They're not sick enough to get a heart and a kidney transplant, but they're not well enough to actually undergo the surgery transplant itself. I think one of the more common things that happens now is, as some people have come to transplant many years into their dialysis course for a variety of reasons, they have significant peripheral vascular disease and their iliac vessels are completely calcified and we can't transplant them. We simply can't use a 6-O-proline to sew the kidney into place. So more often than not, those are the issues that we face. The ones that are cardiac and atherosclerotic burden of disease is more common.
Oh, thank you very much. Those are my questions.
Thank you, Dr. Kigongo and Dr. Becker. It looks like Dr. Simwe has another question.
Yes, thank you very much, Dr. Yolanda. My questions are mostly program. Compare the living donor program, where you have more cases, more donations, and how easy people consent both for living donor and also for that.
I could barely hear you.
That again.
Oh, that's what.
Compare the cadaveric and the living donor program. What are the percentages? Which one do you do more, the living donor or the cadaveric transplants? Then also, what's the consent rate? Which group is more willing to donate, the living donors or the cadaveric? How easy is it?
So that is actually a very interesting question. So it depends upon the demographic. The University of Chicago is on the south side of Chicago, which economically is more strained. And so our population of patients that I take care of and that I transplant is about 85% African American. So we have about a 20% rate of living donation. 20% of living donors and 80% are deceased donors, because many of our patient population, I tell them, please bring a friend, because very often what happens is that we work up about 10 to 15 patients for every one person that we say is okay to be a donor, because of the burden of hypertension and kidney disease in our African American population. And in our populations of color. Therefore, so we do a lot of service, I like to think, for people who think that they're very healthy, and we find that they have significant hypertension. So we're able to put them into primary care positions and, to see the primary care physician, but we work up about 15 people for every one donor that we do. We do about 120 or so kidneys a year. So really only 20% of those are living donors. If you contrast that to Madison, Wisconsin, or a place like Northwestern, which is on what's called the Gold Coast of Chicago, and I mean this in no way to be disrespectful of what they do or in any way to look askance or anything like that. It's just simply the demographic. So they're on the Gold Coast, and Madison, Wisconsin's demographic is also very different than ours. So in those areas, 80% of what they do is living donation. Of that 80%, nearly 95% is Caucasian. And then the 20% is deceased donor. And of that 20%, nearly 80% is African American. So there really is a very different type of patient population that presents. So it really depends upon the center. But we try to work up as many people as we can. If nothing else, if we rule them out as a donor, that means that we may have discovered some disease that we are intervening with much, much earlier in its course than we otherwise would have. So we feel that that's an important service that we provide.
It looks like we have a question from Dr. Henry DeBonja. And let me know if I didn't say your name correctly.
Yeah, you have. Yeah, thank you so much for the presentation. My question is about patients who get kidney rejection after transplant. Is there a different protocol that has to be followed after that, and what duration of time? Is there any particular duration of time that has to be given between the first transplant to the next trial? And what again happens if the patient gets a second rejection? What happens? Thank you.
Yes, some rejections are easier to treat than others. Sometimes we just have simply a cellular rejection, which we can give a little bit more steroid and reverse it. And patients can continue to maintain their kidney transplants. Some that are more difficult to treat, the antibody-mediated rejection, we certainly have got to think about things like plasmapheresis, or even nowadays eculizumab, or switching their immunosuppression around. So we have a lot of different protocols to treat rejection. And we will treat it until the kidney no longer functions and the patient has to return to dialysis. The patients can be relisted for kidney transplant in the United States as often as whenever they need it, whenever they meet criteria. So if they've had a kidney transplant whose creatinine clearance is less than 20, we can actually relist them. So I think the most transplants I've done in somebody, they were on their 5th or 6th transplant. You just keep taking the old ones out and putting the old ones on top of it, or finding different places to put them. So we do a lot of retransplantation, and certainly for people who've gotten transplants as young children. And sometimes they get through their teenage years, and no matter what you tell them, they're just not adherent to the medication. So we have to deal with that as well. But we will retransplant. If somebody's been horribly non-adherent and we feel like it might be a waste of another organ, then they would be ruled out.
There's another question.
Yes.
Hello?
Yes.
Hello? Apart from the iliacs, where else, what are the other options, the positions of transplant? Because I think the only position I know of is the iliac. And the other position, how does the kidney get supported?
Yeah, so, we're almost always on the iliacs. I've done some unusual things in my career where we have done an orthotopic kidney only when we know from our urology colleagues that the native ureter is okay, because obviously a transplant ureter is much shorter. So if we take an old native kidney out, which we normally leave in, and put a kidney on top of that, then we have to have native ureter so that we have a place to drain, or an ileal loop. I like ileal loops less because patients certainly get constantly colonized. They get a lot of urinary tract infections with a loop. But we either do a loop or they have to have native ureter. I have actually used, when patients have had significant venous stenosis or thrombosis because they've had so many dialysis accesses, I've certainly placed the kidney drainage to a gonadal collateral vessel. So sometimes you just have to be kind of creative in what you do. But generally speaking, we're using the iliacs.
Okay, thank you so much.
Thank you. And it looks like we have another question from Dr. Asimwe.
Very much. You earlier on mentioned that vascular reflux is almost a given. Is there anything that can be done to prevent it or manage it, or the patient have the transplant patient have with it?
I'm sorry, I missed the very first part. To reverse.
A vascular reflux in the transplanted
the reflux.
kidney.
Yeah.
Yes.
Well, that, if the patient hadn't had stone disease and has a native ureter, very often, the native ureters, unless the patient had pediatric disease and posterior urethral valves, the native ureters can sometimes be very useful if they don't if you absolutely need somebody to not reflux. We do the leash technique where we reapproximate the detrusor muscle. However, sometimes you can make the tunnel a little bit longer, and that helps. Some will do a Ledbetter-Politano, which is a slightly different technique to implant the transplant ureter so it doesn't reflux. Usually what I try to do is actually just transplant the ureter in my usual position at the dome of the bladder. I don't make too long of a tunnel because sometimes that leads to scarring and obstruction. And then I work to make, sometimes we do the biofeedback models. We work with our urologist to make sure that the bladder is actually functional and stays empty, because we know that it will probably reflux. But as long as we keep the bladder functional, teaching patients how to double void, teaching patients how to do the self-cath and clean cath, that is actually probably our most effective tool. Sometimes we do have patients on long-term antibiotics, but less often so.
Thank you. My last one is a request. Is it okay if they shared with us the recording so I can listen over and over again?
Oh yes, absolutely. I'm sure they will, and I'm happy to send you all an email of my slides.
Oh, thank you very much.
Well, it's certainly been a pleasure talking to all of you today, and I look forward to future collaborations. And if there's anything I can do to help, please let me know.
Thank you so much, Dr. Becker. We really appreciate you presenting your expertise.
Great. And have a good evening.
Thank you very much, Doc.
Thank you. Bye-bye.